Hi, welcome to AFib Awareness Month Facebook Live series. Today we're going to be talking with Dr. Kang about treatment options. I'm privileged to be here with him today. If you missed last week, we were with Dr. Ishu Rao, a friend of Dr. Kang's, and we were speaking with AFib patients just like you. And don't worry if you missed it. What you can do is you can go to our Facebook page, Get Smart About AFib, and you can find it there to rewatch. But let's get into it, Dr. Kang. Yeah. So why don't you tell us a little bit about yourself and your practice?
Yeah, sure. Thanks, Kelly, for having me here. It's a great opportunity to participate in AFib Awareness Month. As you mentioned, my name is Dr. Steve Kang, and I'm a cardiac electrophysiologist practicing here out in the East Bay of San Francisco. I've been here for about 15 years, and originally I'm from the East Coast. I grew up in Maryland, went to medical school at George Washington University, did my internal medicine internship and residency there, and then I headed to the West Coast. Went to Los Angeles, Harbor UCLA to do my cardiology and my electrophysiology. And then when I finished in 2004, I moved up here to Oakland, and I've been here for about 15 years. Currently, I do two roles. I serve as the Director of Cardiac Electrophysiology here at Ultimate Summit, which is downtown Oakland Sutter Cardiac Center. And I also direct electrophysiology for the Alameda Health System, which is our local Alameda County facility.
So. Great. Well, the West Coast is the best coast, so
is that right?
We're here. So tell us a little bit about the typical patient that you see here.
Yeah, so practicing in downtown Oakland, it's very interesting. It's a great place to live. We see a lot of different people from different ethnic, socioeconomic backgrounds, and so the patient mix and the population that we deal with is very dynamic. I'm an electrophysiologist, so I mainly deal with people with abnormal heart rhythms, so we call that arrhythmias. Most of the time these people are seen by another physician, so either their primary care doctor, an emergency medicine physician, or perhaps another cardiologist that has an abnormal heart rhythm or suspicions for it, and they refer them to see me. And most of these abnormal heart rhythms, these arrhythmias, people can have rhythms that are too fast, they're too slow, they're too irregular. And we try to investigate what that is, try to identify what the problem is, and how we can help them. Atrial fibrillation obviously being the big one.
Sure.
The most common abnormal heart rhythm in our community and in the world. So.
And how are they usually feeling when they come in? Are they pretty symptomatic, or does it just depend?
Yeah, so the AFib patient can present in a variety of different ways. I think for some people it's really obvious that there's something wrong. So they come into the emergency room, they think they're having a heart attack, they're having chest pain, palpitation, shortness of breath, and the emergency medicine team can diagnose it with an EKG, for example, and those are pretty obvious. But I think for most people with AFib, some of the symptoms can be a little bit more subtle. So one of the most common complaints that I hear is fatigue. People with atrial fibrillation all of a sudden feel that they don't have the energy or the endurance or the drive to do things that they would normally do, like take a walk up a hill or play a sport or something like that. And sometimes it can even be more subtle than that. Sometimes people may just not feel well, but they can't really describe it.
Right.
And for some people, they may not feel it at all. There's a certain percentage of people and certain episodes of atrial fibrillation that are truly asymptomatic. Maybe it's when they're happening when they're asleep, so they don't wake up, they don't know it, or they really just don't feel anything wrong with them. It was picked up by some incidental finding. They were having another procedure and they were on a heart monitor. They showed up for a routine history and physical on a yearly basis, and the primary care doctor said, hey, your heart rate sounds irregular or maybe a little bit rapid.
I see.
So it can present in a variety of different ways, but I always remember one of my patients, he was in his mid-60s, describing his symptoms was saying, I just felt like I was getting too old too quickly. He felt like he got 10 years older in the past year when he developed atrial fibrillation. And I think that's the thing that most people will share in common, their symptoms.
So when your patients come in for their first consultation, describe how that process goes.
Yeah, so meeting AFib patients for the first time, even before we say hello, there's a little bit of prep work that we like to do. So because they're being referred from other doctors or other healthcare systems, it's really important that we get all of that information so we can review it ahead of time. Because a lot of times the diagnosis has already been made. They captured it on an electrocardiogram or on some heart monitor, and As an electrophysiologist, we want to see that data firsthand. We want to review it personally to make sure that the diagnosis is correct. So there's a lot of that prep work that goes on even before we say hello. And then the first consultation, really, there's several goals, I think, in it. One is for me to get to know the person, how atrial fibrillation affects their life, their symptomatology. But on the flip side is for the patient to get to know me, what I'm like, what my values are, and what are the things that I can do for them. So we spent a lot of time in the beginning just talking, having a conversation, having them do most of the talking, just listening to, telling me how that AFib really affects them, what they feel, what are they doing that makes it happen, the triggers, how is it affecting their quality of life. Things we want to know and want to hear about is, what are the things that you want to do that you can't do? What's the way that you want to live your life, but I can't because I have this recurrent problem, this atrial fibrillation. We delve a lot into other medical issues that are related to AFib, other concomitant diseases, family history, certain lifestyle habits can affect incidence for atrial fibrillation. We spent some time doing an exam, looking for clues of whether they're in atrial fibrillation now, how are they doing, how's your heart rate, listening to the heart carefully, are there other heart problems like valve issues, heart murmurs that are important. And then we spent a lot of the end of the visit really just sort of reviewing what my thought is of what they have in terms of what the atrial fibrillation is like, how severe is it, what further things we need to do to get more information, more heart testing like an ultrasound or blood test. And then spend a fair amount of the time ending it about what are the things that are we worried about. Are we worried about stroke risk, how we can help you with that? How can we slow down your heart rate? How can we make you feel better? And then develop a short-term strategy so when they leave the door, at least we're making steps forward for immediate management, but also discussing what the long-term strategy can be. How are we going to prevent the problem? How do we change lifestyle habits or treat other medical conditions? Do we need to look at long-term medicines or procedures like ablation or, in some people, surgery? How we can try to stop this problem and treat it and control it. Because for most patients, AFib is a lifelong illness.
Right.
And this relationship that you're going to develop with any healthcare provider, but an electrophysiologist that deals with AFib, routinely, you're really developing this lifelong relationship in the office. So.
It sounds like the steps that you take really set up a trusting relationship. And I love the way that you present giving the patient back some of the control by offering up some of the steps that they can take immediately when they leave. That's really great.
Yeah, that's really important. I think, like any relationship that is important, that you want to be long-lasting, you have to have that trust and that communication. And, I think certain patients, they just want to be told what to do, right? They want to think about it, and that's fine. I'm happy to play that role in that relationship, but I think it's actually better when the patient on the other side, where we're like on equal footing. I'm here to advise you. I can sort of give my opinion, but I want your opinion because we're going to make decisions which can be life-altering, that are very important, but we need to do them together.
Right.
We need to be on the same page. And if I'm not explaining something that you don't understand, that's not a good relationship. And if you're saying something that I don't understand, we got to work that out because we're going to go down this road together in this pathway, and hopefully, it'll be a relationship that's going to last a very long time, and to bring you to a better place.
Absolutely.
So I think that's really important, but that applies to most things in medicine and other things in life.
Right,
so.
Right. And last week we heard from both of the patients as well as Dr. Rao that one of the important things to do during that first consultation is to bring a support network, like maybe one other person with you. Would you agree with that?
Yeah, I think that's a great idea. I know Dr. Rao personally, and his relationship with patients are very meaningful, and I think that's something that you can be taught, it can be learned, but a lot of it's also just the way you are as a person. But I think having someone there who, another voice, another ear, someone to get in the conversation can be very helpful, because a lot of times, honestly, people who come to see me for AFib, they don't want to be here. Right. They don't want to come and see me because they know something's wrong, and I may be suggesting something that might be intimidating or a little bit scary, and having someone to reassure them or re-ask the question in a different way or hear an answer, I think that's very helpful. Because we manage AFib as a team.
Right.
It's a team approach, even from my side as a provider and procedures and medications. We have a whole staff of people that deal with this problem. And I think on the flip side of someone who has AFib, it'd be nice if you had your own AFib team, right? And getting on something like Facebook and communicating with other people and different websites is very helpful. And AFib is a community now.
Yes.
because it's unfortunately a growing community. You know?
Yes. Yeah. As with anything else, it takes a village sometimes to
Right,
conquer
right.
a problem. So you've had the consultation with the patient. What happens next as far as your diagnosis process for AFib?
Yeah, to diagnose atrial fibrillation, you really need to see it. So I think, any way that you can record a heart rhythm tracing at the time of an episode of atrial fibrillation will be enough. The real challenge is to catch it at the time you're having an episode. So for some people, they're in atrial fibrillation all the time, and no matter whenever you get the heart rhythm recording, like with an electrocardiogram, which is a non-invasive, painless heart recording with electrodes, sticky electrodes on your arms and your chest. That's the best way to diagnose it. But the real challenge is for people who don't show up in the office in atrial fibrillation, right? They had it yesterday, and then they show up to your office and they feel fine, like going to a mechanic, right? My car was making this noise, but today it's not.
Yeah.
I swear it was there. And it's really trying to figure out how you can catch that. And the way we try to document it better is we use longer monitors. So there are certain monitors that you can get wired with sticky electrodes. Not as sophisticated as an EKG, but like a Holter monitor you can wear for a day or even up to 3 days. That's a little bit cumbersome. There's other monitors that are what we call event recorders, or little cards that you can put on your chest to do intermittent recording if you feel something. There's monitors you can wear for up to 2 weeks or even a month that can continuously record everything. And some of these are now like internet-based, where you can send data directly to us. But for some people, if it happens very rarely, maybe once a month, or we suspect that AFib is really there, but we're not able to catch it, there are ways for us to even monitor for years at a time. We now can inject small recording devices underneath the skin, literally in a 10-minute procedure that can record every single heartbeat for up to 3 years. It's a looping memory system. Patient can activate a recording, they can transmit it over the internet to us. And we call this implantable loop monitors. And lastly now, even beyond just using the technologies that I use in the office or can do, with wearable devices being such a big thing now, there are commercially available products that people can purchase, on any other web-based place you can buy stuff. And they can buy up their own heart recording systems that can link up to their smartphone. So there's a lot of ways to do it, but the key is to be persistent and really document that you have AFib, because it really is important to have that piece of information.
In one of the first programs that we did, we were teaching how to take your own pulse. It's something that not necessarily everybody knows how to do, but as you say, very important if you feel like you're having a heart arrhythmia to be able to diagnose that right away.
Yeah, and the best time to check your pulse to practice is when you're normal, because then you know what it feels like, and this is sort of normally me. And that's what a lot of the wearable devices are doing now, like, these smart watches coupling up with different health systems and trying to figure out how they can detect arrhythmias just by wearing a watch, for example.
Right.
And I'm part of Stanford Healthcare, and we have a project, one of my colleagues at the School of Medicine is working with a very large technology company trying to figure out how that they can do that in a mass screening way. So people are definitely looking at it. Yeah.
Initiative. So when a patient comes in and let's say you have diagnosed them with AFib, how do you explain the disease to the patient?
Yeah, so how to explain atrial fibrillation? Really, you got to think of AFib as an electrical problem of the heart. So we often think of the heart as a muscle pump. It squeezes, it pumps blood, it gives us our pulse, our blood pressure, and that's definitely true. But the heart is very electrical, and it's actually the electricity in the heart that dictates how and when the heart squeezes. So atrial fibrillation comes from the atrium. These are the top 2 collecting blood chambers of the heart. And the bottom pumping chambers, we call the ventricles, give you your pulse and your blood pressure. And so the top chambers collect blood, squeeze, fill up the bottom, therefore you get a good pulse and a blood pressure. So the way it works is the electricity pattern in the heart is very well timed and coordinated. And we have our own natural heart timer, everybody does, we're born with it, that tells us our heart rate's going to be 60 beats per minute while we're sitting around doing nothing, for example. And this sinus node, we call it in the atrium, releases out an electrical wave. And this wave of electricity flows through the heart muscle in a very even, coordinated way in the atrium squeeze. Fill up the bottom, then the wire signals go down through special wires, and then the bottom squeezes, and then you get your pulse and your blood pressure. In a way, atrial fibrillation is an abnormality in that electrical wave. So there's really two ways you can look at it. This electric grid of the heart muscle, either there are other areas that are driving the heart rate, so it's not our sinus node, but there are other parts of the heart that are very excitable, sending out rapid electrical signals. It could be one, it could be shifting, it could be multiple at the same time. And because this electricity is so rapid, the electricity is disorganized.
Okay.
The second mechanism we think is electricity wavefronts like to move in a very smooth, even way. So imagine like you're looking at a stream and water's flowing down nice and evenly. There's no obstruction in it, but all of a sudden, a tree branch falls down from a tree and gets stuck in the stream.
Right.
And all of a sudden, the water has to go underneath, it has to go around, it has to go over, and you see these little currents and channels pulling around. And it's another way that the electric grid is disrupted. And so atrial fibrillation is a combination of this too. It's a disruption of the electrical grid, and the end result is that this electricity is unorganized, it's uncoordinated, it's rapid and irregular, and the muscle squeezes that way. It squeezes rapidly and irregularly, and it can't squeeze very well, it quivers. And they call it fibrillation because it fibrillates as opposed to squeezing. And that's where heart function, blood flow gets reduced, and people feel short of breath, they feel tired, don't have the endurance. Pulse is fast because the electricity is fast, and the ventricles beat quickly, they can feel chest pain, palpitations. So it's really a disruption of the electric grid, thinking that the muscle is electrical and not just squeezing.
So it's making the heart work harder than it should be.
Yeah, I think that's a good way to put it. It is. Resting heart rates are usually fairly slow, but AFib patients, the heart rates can be over 100. When a person with atrial fibrillation goes to walk, normally your heart rate accelerates like this, but AFib patients, they can accelerate like this.
Okay.
And so it does make the bottom work harder to a certain degree because it's driving it faster all the time.
I see.
Yeah.
And is there someone who's more likely to get atrial fibrillation than another?
Yeah, so the people who most often have atrial fibrillation are people who are older in age. If you look at statistics, of all the AFib patients that we have in this country, 1% of them are less than 60 years of age. But if you look at people who are over the age of 80, then it makes up 1/3 of the entire AFib population.
Wow.
So age and atrial fibrillation risk correlate very closely together, and it's not a straight line. It's actually the older you are, and every decade you advance, we think that the risk of developing AFib doubles. But it's also because older people have other medical diseases that cause AFib. So they have more heart problems, like heart disease, have a heart attack, or a heart valve problem. They could have heart failure where the heart muscle in the bottom is weak. We call that congestive heart failure. But they also have other risk factors that over time, in many years, even though they may be well controlled, can still damage the heart in a very slow way. So hypertension, for example, diabetes, high cholesterol, being overweight or obese, smoking chronically can damage the heart, and things like high alcohol consumption, not necessarily a disease, but these are habits that we have that can damage the electric grid and create triggers or circuits. So all of these can play together, but if you look at the number one predictor, it's age. And the last thing we're learning a lot about now is, and my colleagues down at Stanford are really looking into the genetic mechanisms of atrial fibrillation. So, we now realize that if you have a first-degree relative, like a parent who has atrial fibrillation, especially at a younger age, that your risk is increased as their child, especially both parents, is markedly increased.
Sure.
And so they're looking at ways to understand what the mechanism is from a genetic standpoint, really helping us to identify maybe these patients are more at risk, and then to understand a little bit more about how the disease happens from that standpoint. So.
Great. Yeah, we had several questions from our patient population of whether or not AFib was hereditary.
Yeah, I think from a purely electrical standpoint, there is evidence that can be the case. But a lot of these other diseases that cause atrial fibrillation, not directly inheritable, right? But things like obesity. If your parents are obese, you're more likely to be obese. If your parents have diabetes, you're more likely to be diabetic, hypertension, etc. And all of these things, can damage that electric grid over time and cause AFib.
Okay. And why is AFib a risk factor for stroke in many of those patients?
Stroke is obviously a big consequence of atrial fibrillation. We think that atrial fibrillation is the number one identifiable cause of stroke, especially a clot stroke in our country. And the reason why it happens is basically if you form a blood clot in your heart and that blood clot doesn't stay in the heart but leaves, it can hit the brain. And if it blocks an artery in your brain, brain tissue can get damaged, and that's a stroke. If it misses the brain, it can go somewhere else, to your leg or to your kidney, right? So that's not a stroke because it's not your brain, but it's still the same mechanism. And the reason why that happens is, as I mentioned, when the electric grid is disturbed and the electricity is very uncoordinated and rapid and irregular, and the atrial muscle chamber is not squeezing to pump out its blood's kind of stagnant in there. It's just pooling around. And there's a particular area in the left side of the heart called the appendage, which can be a large pouch in some people where blood can just pool and not move. And when blood doesn't move, it wants to form clot. It's just the natural mechanism of blood. So blood really wants to always be moving to stay fluid. And if you get a clot formed in there and it leaves your heart, it gives your brain that stroke risk. But the other flip side of it is not necessarily, we think a lot of that is the mechanism for stroke, but we also have to realize that patients with atrial fibrillation also have a lot of other risk factors for stroke too. So if you look at the things that we talked about with heart disease, heart failure, diabetes, for example, all of those alone without atrial fibrillation increase stroke risk.
I see.
So they kind of go hand in hand, but the blood clot is the one thing that we really worry about, and that's why we use medicines to try to prevent blood clotting, to protect people.
Okay, all right. So earlier on you were talking about after you've made the diagnosis, one of the important steps is to identify what are the triggers of a patient's AF. How do you identify what that is? What are the triggers?
Yeah, triggers for atrial fibrillation can be pretty varied. So some people, just looking at their history, are pretty clear that if they're going to do something, they increase the risk of AFib. And so for some people, it's like a high adrenaline state. They're very tired, they're stressed at work, they're emotionally upset. If they drink a lot of stimulants, Monster drinks, Red Bulls, a lot of coffee, that can be a trigger for them. But it's actually very interesting because on the flip side, you'll have people who have triggers that seem to be just the opposite. So they only get AFib when they're sleeping at night. They'll get atrial fibrillation when they eat a big meal or they drink something really cold. And even though that's kind of an opposite from stress, it's more relaxation, we think. It just shows the complexity of the interaction between stress and relaxation in the heart. That balance needs to really be maintained. If it's disturbed, you can get AFib. For some people, alcohol we know can be a trigger. There's a syndrome we call the holiday heart. On the weekend, people go out and enjoy themselves and then maybe drink more than normal, and then on Monday, before they go to work, they're in atrial fibrillation. So I guess you would call that a weekend heart. But so that's another possibility. But for some people, we don't know why they get it. There is no trigger. There's no rhyme or reason. It's a totally random event. It's important to know because people can avoid triggers, modify the way they live. It can help reduce the burden of atrial fibrillation. Oftentimes it doesn't make it go away completely, but it's enough to improve that.
Right.
Which is important because that doesn't take medicine or procedures or anything like that.
So what is the typical treatment pathway for an AFib patient?
Yeah, so treatment pathways for AFib, it's a little bit multi-pronged. But I think you can really think of, there are four things that we're really going to try to address, and four pathways that are not mutually exclusive and they overlap in several ways. One of the first things we talked about is stroke. So all AFib patients need to get an idea of what their stroke risk is. For most people, it's pretty easy. Most people with AFib are high risk for stroke. They should receive some type of protection, whether it's a blood thinning medicine that you take as a pill, or for some people, whether it's a procedure to close that appendage or even surgery. And it's really looking at the people that are the low-risk patients who maybe don't need anything because their risk is so low, or maybe even something like an aspirin, which may have some benefit, we think. But that's really a pillar because the consequences of stroke and AFib are really huge.
Okay.
So that's certainly a pathway, and that's often a pathway that we walk together long-term, indefinitely, because that risk of stroke may persist despite what we do for other things with AFib. The second thing we worry about in the pathway that we try to manage is the heart rate. So remember, it's fast, rapid electricity. The bottom pumping chambers can be very fast, and people don't like that. It doesn't make them feel well. So we give medicines like beta blockers, calcium channel blockers. Less often we'll use digoxin now, but to try to slow down the pulse, which can relieve symptoms. And it also protects the muscle from getting too tired over a long period of time.
Okay.
So imagine if you're running a race, sprinting all the time, you're eventually going to get tired. And the same thing can happen with the heart muscle on the bottom, and then you can develop something called congestive heart failure. The third thing we focus on a lot more now is modifying the risk factors that promote AFib. So we mentioned a lot of them, and really getting more aggressive on trying to eliminate or better control the conditions that damage the electric grid.
Okay.
So if you're overweight or obese, really referring to nutrition or getting in a weight loss program. If you have sleep apnea, for example, seeing a sleep doctor, getting that treated. Making sure diabetes is controlled, documenting blood pressure control, reducing alcohol, quit smoking. And that's really a comprehensive approach that on our side we do with other physicians and healthcare providers. But on the flip side for the patient, they need as much support as you can. One of the hardest things about quitting smoking or losing weight is doing it by yourself.
Okay.
So the last thing we focus on is a rhythm control pathway. So for many people, they don't like having atrial fibrillation. Even if the heart rhythm is controlled, even if they're on a medicine to protect them from stroke, they just don't feel well.
Mm-hmm.
And so we go down a pathway where we try to restore normal rhythm, either with electricity or medicines, we call that cardioversion, or using other means to prevent AFib from happening down the road. And those things include heart rhythm drugs like antiarrhythmics, these heart rhythm stabilizers, catheter ablation to try to eliminate triggers and circuits, and for some people, heart surgery, to do the same thing.
Mm-hmm.
So.
Okay, so specific to the drug therapy potential pathway for treatment, can you tell us a little bit about those drugs that you may prescribe?
Yeah, so the drugs that we use to prevent atrial fibrillation, we call them antiarrhythmics or heart rhythm stabilizers. And they have electrical properties that try to prevent the heart from being irritable, from skipping beats. In a way, when I talked about the electric grid being disturbed or electricity is going fast and slow in some areas, these heart rhythm drugs try to even that flow.
Okay.
And that way you can reduce the burden of atrial fibrillation.
Mm-hmm.
One of the things to remember about medications is that there is no medicine cure that we can give people to get rid of atrial fibrillation for most people. It's not like you have an infection, I can write you an antibiotic and we expect that infection to go away. A lot of these medicines are more suppressive, they're palliative. And we give them in two different ways really. If your atrial fibrillation is infrequent, you take it when you have an episode so you can terminate it more quickly. But for a lot of people, they need it prophylactically. They take it every day to prevent episodes. And even then, we tell people that successful drug treatment consists of the drug is safe for you. Mm-hmm. You tolerate it so you don't have side effects. You're okay taking it every day, and you're okay taking it indefinitely. But most patients on heart rhythm drugs will have atrial fibrillation. It's just the nature of how the medicines work. But that's usually how we will initially start people when we try to manage the rhythm. Is using these heart rhythm stabilizers.
And if a patient is asymptomatic on that, can they stay on those drugs for a prolonged period of time?
If the heart medicines are well tolerated and they seem safe and it seems to be effective, that is a reasonable strategy to do for some people. And some people, will choose that because they'd rather take a medicine than do something more aggressive or something invasive. Because the strategy for rhythm control can change. It's dynamic. So if things are working well for a certain period of time, but then things start to break through, we make an adjustment. We readdress the issue, reevaluate, whether that means changing medicines, taking more medicines, or doing something invasive. Each step of that process we reevaluate and sort of look at those treatment options.
Okay.
But some people will stay on medicine for a long time.
Mm-hmm.
It's just the one thing we worry about people on medicines every day indefinitely is progression. So, we worry that atrial fibrillation statistically gets worse for people, longer episodes, higher frequency, and having atrial fibrillation can damage the electric grid. Electric grid doesn't like to be overstimulated. So it's really keeping track of that either through symptoms, maybe getting serial picture studies to make sure that the atriums aren't really getting big, which implies damage and scar. But it is something that we think about and just track and watch closely for people who choose to stay on medicine.
So you're still seeing those patients pretty frequently, even if they aren't experiencing symptoms on the drugs they're on?
Yeah, we do, because we want to make sure that the drug is still safe for people to take. So people's conditions change. Heart function's got to be good for certain drugs, otherwise it's dangerous. People have certain conditions like having a heart attack cannot take certain medications.
Right.
So even though we have several medicines to use, you have to use the right drug for the right person at the right time. And then we have to follow them, over the years that they're on it.
It sounds like it's extremely customized.
Yeah, it's a long-term relationship, and it's a medicine that we keep track of routinely.
Okay.
So, yeah.
So let's talk a little bit about the patients who cannot tolerate the drugs. Can you tell me a little bit about the option that you discussed for ablation therapy?
Yeah. So a fair number of people either don't tolerate medicine, the medicine doesn't work well enough, or they just don't want to take medicine. These are people we call who are refractory and intolerant to antiarrhythmic drugs. And so there is a procedure that electrophysiologists commonly do, we call it catheter ablation or atrial fibrillation ablation. And that is an alternative to using these medicines to control heart rhythm.
Okay.
And right now, mainly we're offering it to people who have symptomatic atrial fibrillation. And they're what we call paroxysmals. They're people who have periods of normal rhythm, but then they have atrial fibrillation, but then they come back to normal rhythm on their own, whether they're on medicine or whether that's the natural course of their disease. Most of these patients will have at least tried one heart rhythm stabilizer or have failed one heart rhythm, they just don't want to take it. And actually our professional societies, American Heart Association, American College of Cardiology, Heart Rhythm Society, have recommended that ablation can be useful for these patients.
Okay. And what factors are considered when deciding if a patient is going to have an ablation?
Yeah, so the factors to decide who ablation might be appropriate for, we kind of look at it maybe two different ways. So one is more from a procedural standpoint and one's more from a personal standpoint. I think from a procedural standpoint, we want to look at the overall health of the patient, the overall healthy person. Do they have conditions that we can treat with ablation but not have to worry about down the road with surgery? So people with heart valve disease, we can fix circuits today, but if there's a really bad heart valve problem, new circuits are just going to happen. So we look at the health of the atrium. We can take pictures of it either with ultrasounds or other imaging to see. Bigger atriums imply more damage. Not to say that it precludes people from having an ablation.
Right.
It's just that it sets more realistic expectations. And then we look at personal factors. How well do people tolerate medicine? What is their goal? How comfortable are they having a procedure that's invasive but non-surgical to try to arrest and stop this problem?
Right.
Yeah.
So I imagine some people question, is ablation right for me? What can patients expect before the ablation? What do they need to do to ready themselves for something like that?
Yeah, I think so before a patient has an ablation, I think for all people who choose to have it or not, what you really need to have is a clear understanding of the nature of the procedure, right? So it has to be explained to you almost in a step-by-step way, and then understanding what's the benefit and what's the potential risks of that. I think when you talk about who's eligible for ablation, I think many patients are eligible for ablation. It's more of a personal choice whether they choose to have it or not.
Okay.
Or maybe it's more of the preference of the person that they're seeing who's managing their atrial fibrillation. So we as electrophysiologists do a lot of AFib ablations, but maybe general cardiologists, they don't do these procedures, and so maybe they're more comfortable not referring for an ablation. I think so that's the most important thing, is to understand that. And there are some logistical things that we do before ablations, just like any procedures or routine blood tests. Sometimes we'll get imaging of the heart to create a three-dimensional model, so we don't have to use as much X-ray to see things when we're moving. Some people will actually get a picture of their heart through their esophagus with an ultrasound probe to make sure they don't have a blood clot in there already, so it's safe for us to do procedure. We usually like to keep people on blood thinners if they're on it up to procedure and sometimes through the procedure. We're very meticulous about that because we worry a lot about stroke risk. Usually if you're on a heart rhythm drug every day, to treat your AFib, we want you to stop and let it wash out before the procedure, because we want to see your heart native. We want to see the disease totally open. It helps us maybe find other areas that we need to attack during the procedure.
Okay, all right. And I know you brought a heart model and potentially some catheters with you today. Can you take us through the ablation procedure and describe what happens when you're doing the mapping?
Yeah, sure. So for the patient perspective, most people sleep through the entire thing. So because we use general anesthesia routinely. But this procedure is performed in an electrophysiology laboratory with usually an EP lab staff. In our facility, we have about 3 or 4 people in the room and an anesthesiologist who uses general anesthesia routinely. So you can expect to sleep during most of the procedure. And it's for both parties, because for you it might be more comfortable. You may not feel lying on the table for several hours, maybe moving around things in the leg you may not like. But also for me, because you don't move, you don't feel discomfort, you can control your breathing, so everything is very stable. Everyone usually gets a blood pressure line, so some type of IV, and we usually go through the legs. So that's the way most people are doing it. It's non-surgical, putting IVs a little bit larger than what you get in your arm down in the groins, and either using some X-ray or using these 3-dimensional GPS tracking systems. We'll put wires up into the heart and spread them out.
Okay.
These give us like an EKG from inside the heart. Here, I'll show you these. We use these wires where you can bend them and place them in different places, and they have these little electrodes, and they can record heart electricity.
Okay.
And usually the process begins once we're inside the heart. We create a geometry. So we have a picture from the CT scan from before. We'll create a 3-dimensional model of our system using a mapping system of some kind. And basically what these are, they're like GPS. They create some type of field. We're moving the wires through. We can see where we've been, and we can create a real-time 3-dimensional model. And it helps us to understand the anatomy, helps us to track where we're going, helps us where we want to go. We have direct visualization real time.
Okay.
And oftentimes we'll put in an ultrasound camera up in the heart through one of the veins. We call that an echocardiogram as well. And then most AFib comes from the left side of the heart, around these lung veins that are draining into the back of the left atrium. And so we'll cross over from the right side to the left side. There's a thin membrane, we call it the septum. We use a small needle to get in there. People don't feel it, and the hole usually closes up in a month or so. And then what we do is, after we've created our model, we have target areas that we want to try to get rid of these triggers and where a lot of this circuitry is, usually around these 4 lung veins draining into the left side. And what we end up doing is using energy. In our laboratory, we use radio frequency, and we create a scar line around that whole area. And by scarring the muscle, you create an electrical barrier that electricity can't get out. So if a trigger is trying to start atrial fibrillation in a certain area, it can't exit and make the rest of the atrium fibrillate. It's isolated. And so we'll create this scar line. Once it's complete, we'll check it to make sure it's good. And then, depending on time, most of us will test to see what else we can find, other hidden circuits, other hidden triggers, whether we use that with a lot of adrenaline or other medication. During the procedure, everyone's on blood thinners, so we give that in the procedure, really trying to reduce blood clot formation and stroke risk during the case. And the procedure is usually done in about 2 to 3 hours. It varies in laboratories, depending on what you find. After the procedure is done in the lab, all the IVs come out. We just hold pressure. Some people might put a stitch inside. Most people are get awoken on the table, so they're off general anesthesia before they go upstairs. Some people may say they have a sore throat because we use a temperature monitoring probe in the esophagus, which is behind the heart. We want to make sure we don't heat that up too much. And that usually comes right out after we're done.
So the length of this catheter is this long because you're coming up through the groin and into the heart.
Right. So, for example, this mapping catheter is going to be inserted through the leg, and it's got to reach the right side of the heart. Then it's got to go to the left. This has these multiple poles to help mapping.
Okay.
This is an example of a catheter that we use to create the scar.
Okay.
So this is a radio frequency catheter. It's an ablation catheter. The tip's pretty small. It's about a grain of rice, 3.5 millimeters or so. It's actually very interesting. This is the most modern ablation catheters we have. They secrete water to cool the tip so we can give more power.
Okay.
Our goal is to create a really good permanent scar so the electricity can't come back and escape. These catheters also have little springs in them now, and they can help us determine if we're touching the muscle, how hard we're touching it, and what direction we're pushing. Because contact and stability is really important to create good scar and permanent scars. There's a lot of data to show that the more consistent you are using catheters like this, the better outcome that people have.
Okay.
This is the way a lot of people are doing, using heat.
Do you mind pointing out for me on your heart model, you talked about the septum And then the pulmonary veins,
Yeah, so if this is the heart.
we're just going to lift it up just a little bit.
So the heart has 4 chambers, 2 on the bottom, the ventricles, and the 2 on the top, which are called the atrium. This is the right side of the heart. This is the left side of the heart.
Okay.
If you think about what we're doing in AFib ablation, we're coming up from the leg, we're into the right side of the heart, and then there's a thin membrane that separates the 2 chambers between the 2. So if this is the right side of the heart, this is the left side of the heart. The white structures are the heart valves that separate the 2.
Okay.
We'll jump over from the right to the left. And then what you can see, it's a little bit hard to see, but in the back of this left atrium, I'll turn it around. If this is the left atrium in the back of the heart, these 4 red things, these are the draining blood into that chamber.
Okay.
And it's these areas that we think around where the veins insert, that there's triggers in the veins and around the veins, and that the electricity around these vein insertions is abnormal.
Okay.
It's inserting in a way that the electricity doesn't flow as evenly through. And so our goal is to scar that area to prevent electricity from escaping inside these veins.
Okay, so where you talked about creating the scar, it's usually around those veins.
Right, around we call the pulmonary veins or lung veins.
Okay, all right. Are there any? You showed the catheters. They look very small.
Yeah, they are.
But are there any risk factors that we should be aware of with catheter ablation?
Yeah, of course. With any invasive procedure, there's always risks that are unavoidable. But I can tell you that AFib ablation is very safe. It's a very safe procedure, and in fact, for many of us, it's the most common procedure that we're doing in our laboratories. But we do worry about things. We're putting IVs into a vein, and people are going to be on blood thinners, so we worry about bleeding from the groins. Probably the most common thing that we see. It's unfortunate if there's bruising and swelling. Most often it's not life-threatening, requires anything else, but it can be uncomfortable for people. We're putting up wires in the heart, and we are creating scars, so we do worry about bleeding around the heart, for example. That happens rarely now, given these newer catheters that we have with pressure sensing and vector direction. But we do worry about that. We do have a camera to look for bleeding complication. Many times if we see it, we have to stop, unfortunately, but the heart will heal itself up, stop the blood thinner. Worst case scenario, you got to drain that blood, and we usually use a needle for that. In extremely rare cases, you may need surgery for that. We're using an energy source, so for example, heat. Heat doesn't stay in the heart alone, it can transmit out and can hit other structures nearby, so we do worry about damage from the esophagus, which sits behind the heart. Damage to the lung or the nerves to the lung. And these happen very rarely, but we take precautions for that.
Sure.
That's one of the reasons why we have a temperature monitor in the esophagus. We used to worry about, people often wonder, well, you're taking out some muscle, and don't I need that muscle to make the heart squeeze? And the answer is yes, that's true. We are scarring muscle, and the muscle that we scar is not going to squeeze because we scarred it. But on the flip side is the atrium has a good reserve of heart muscle, and the areas that we take out are pretty localized. So the atrium will still have enough squeeze left in it. And on the flip side is, when you're in atrial fibrillation and you have 100% of your heart muscle, you're not getting any squeeze, even though you have 100% of your heart muscle that can squeeze, because the rhythm is out. Versus if you're in normal rhythm, but you take out a small percentage of the muscle, now the rest of that muscle can squeeze. And I guess the last thing we worry about, we mentioned, is stroke, which is probably the other major concern that we have. Even though it happens rarely, we take a lot of precautions to make sure it doesn't happen, and that's making sure that people stay on blood thinners during procedure, making sure we don't introduce any foreign material like air into the heart itself. So yeah, there are several complications that we worry about. Death is always mentioned as one of them. The risk of death during this procedure is extremely, extremely low.
What should a patient expect after an ablation? Can they return to a normal routine after the ablation?
Yeah, so after ablation, most people are going to spend the night in the hospital.
Okay.
So it's still routine for us, mostly just to make sure that their legs are okay, to prevent bleeding from the legs. In the hospital, you're monitoring the heart rhythm. Back might be sore because you've been lying down so long, throat's a little bit sore and a little bit sleepy from anesthesia, but I promise you, you will be able to eat once you're more awake. And then the next day, most people go home before 12. They're up walking around, and most people go home, actually all people will go home on a blood thinner, usually some heart rhythm stabilizer in the short term. Remember, heat can create some inflammation, so some people feel a little bit of tightness when they breathe in their chest. Usually goes away in a few days, and if it doesn't, then you need to alert your healthcare provider that something might be going on, but most people feel fine.
Mm-hmm.
I think going back to a desk job, 3 days or so is fine. A lot of the restrictions is to protect the groins.
Right.
Don't strain, don't lift too heavy. We ask you not to drive for a couple days, mainly to protect from bleeding in the legs. We usually see people in about 5 days for a wound check in the office, and if everything looks fine, people are welcome to go back to their normal activities, exercise, etc. We like to keep the wounds dry for maybe 2 or 3 days to prevent infection. What we hope is over the next several months, some people may feel some fluttering or some skip beats because the heart's irritated a little bit. Once that subsides and settles, what most people experience is calm after that, where the rhythm is stable, it's normal. And usually around the 2 to 3 month time frame after the heart is fully healed, even though you're back to normal activities within a week or so, we stop the medicines. We stop the heart rhythm stabilizers, just the heart rhythm stabilizers, and we see what happens.
Yeah.
And for most people, they either do not have recurrences of AFib or their AFib is much reduced.
That's great.
And so that's what the benefit of the catheter can do for us.
Absolutely, and I know that many of our patients are eager to find a solution,
Right.
So that's great. So obviously everyone who's watching us doesn't necessarily live in Oakland, so they can't come see you.
You should come visit though.
They should come and visit.
It's a great place.
But what would be one of the most important things as far as for these patients as they are identifying which EP to go and see? How do they go about that and selecting a physician?
Well, I can tell you that there are great electrophysiologists all over the country, right? And I know several of them, people who are well trained. And with regards to atrial fibrillation, I think there's two aspects of it that you want to look at if you're looking for an electrophysiologist specifically to help you. One is, there's the procedure that we talked about, but also looking at more about the professional personal relationships that you can have. And I think, obviously you want your physician to be up to date, contemporary, aware of the latest treatment strategies, looking for trouble side effects, etc. There's board certification for my specialty beyond just general cardiology. So we have to be board certified in cardiology, then been board certified in electrophysiology. And we have multiple meetings that we can attend yearly. So I think that's important from a professional standpoint. I think from a personal standpoint, even though we talk about the AFib population growing and how we manage atrial fibrillation with these guidelines that get published and the AFib population, I think it's really important to find a provider that really understands your atrial fibrillation, how it affects you, and understands what might be best for you as opposed to what we think might be best for the millions of people that have atrial fibrillation. And we see it all the time because we treat patients as young as 19 years old. We did an ablation on a 19-year-old, and that person's atrial fibrillation and desires are very different than the 82-year-old person that we did an ablation of. And they did it for particularly different reasons.
Right.
Even though we say they still have atrial fibrillation, we sort of use the same medicines, we do a similar procedure, but their diseases are different and the people are different. And I think that takes a healthcare provider that really has the time to listen, which is harder these days. EPs are busy people. We're expected to see more patients and do more procedures in the same amount of time. So I think that's important to think of someone who's actually listening to you, and discussing to you what the options and sort of deciding together about what to do. And I also think it's important that you have someone that's fairly local. So in reality, if we talk about catheter ablation, the easiest part of the ablation series is actually doing the procedure for us. It's predictable, it's controlled. A lot of the challenges and really the art of the management comes before people understand the management and afterwards. What to expect, troubleshoot, look for complications. And that really takes a person to be around. So I know that some people may be just doing the procedures and then they travel somewhere else. And I've had people do that because we got a lot of great physicians in this country. It's just that they come back. My feeling is that if you do the procedure, you should take the responsibility of that, and you need to be around to manage that person afterwards.
Absolutely.
But certainly most contemporary centers have the training, the experience, and are working at centers that have the quality, a dedicated lab, a dedicated trained staff to do these procedures. And experience does matter. That's something that you can only gain out by doing many cases and seeing the good, but also never forgetting those rare bad moments that you can learn from. That's a really important part, especially when you do procedures.
So if I hear you correctly, treat it just like you would any other consumer product.
Pretty much.
Okay. All right. Well, right now, Dr. Kang, if you're cool with it, we're going to transition to the Q&A from the Facebook Live feed. And this is one of my favorite parts because it allows our patients out there to connect directly with you, the expert. So we're going to start with a question from Linda. So Linda asks, how important is diet in relation to AFib?
So diet in relation to AFib, they're definitely related. So whatever you choose to eat and put in your body is going to affect your body in general. And with relation to AFib, I think, are there specific foods that can make AFib worse for people or triggered? And the answer is for some that is true. One of the things that we hear about is chocolate, caffeine. We talked about alcohol. But I think you also have to think of what foods you're eating and the diet that you have is looking at the overall heart health, because the more ill your heart becomes for whatever reason, hypertension, diabetes, heart attack, the more likely atrial fibrillation can happen. So I don't have a specific atrial fibrillation diet that I tell my patients to eat. If they tell me certain things make AFib happen, I tell them don't eat that, right? But make sure you watch how much fat you eat. Don't eat trans fat. Watch your caloric intake. Watch your carbohydrate intake. Watch your cholesterol. All the things that we should be doing anyway, even if we were healthy anyway and wanted to stay healthy in general. But certainly foods can affect people. And one of the things, as I mentioned, about the amount that you eat, for some people, that can be a real trigger. And so we tell those people, don't eat so much. Don't skip meals, eat smaller meals more regularly during the day. And that can really help at least reduce that as a trigger or some burden. So, but
good
it's
advice.
A great question, yeah.
Yeah, very good question.
We're learning more about it, so diet is one of these things that affects everything, but how it affects something specifically, it's always a little bit harder to pin down. There's a lot of causal and associated relationships, and we're really trying to figure out the nutrition part, independent of just being overweight and obese, but they are directly related, AFib and weight.
Right, and some of that work that you mentioned that you're doing for the studies with Stanford and your colleagues on the hereditary side.
Yeah, looking at those risk factors, whether there is a predisposition for obesity or not, whether their parents were totally healthy people, athletic, whom you think would never have a problem, and for some reason they get AFib. It's the bad role of the genes, so to speak.
Right. Okay, next question comes from Carolyn. Carolyn asks, once diagnosed with AFib, will you always have it?
So once diagnosed with AFib, will you always have it? And my answer would be hopefully not.
If you have anything to do with it.
Yeah, it kind of depends. So most people, when they get atrial fibrillation, it's a primary electrical problem. So for some people, they'll get it when they had pneumonia, or they were sick with something else, or they had a procedure or surgery. Then you see it then, and then that inciting event is done with. We call those secondary atrial fibrillation events. We don't expect you to have another spontaneous one when you're healthy, but you might be at risk if you have another event, for example, if you get sick again. I think, with living with AFib, whether it's a lifelong illness, it depends on how you manage it and what kind of atrial fibrillation you have. So I do think for some people, we cure this heart rhythm problem, especially the people that are healthier and younger, like the teenager that I gave an example of. And we've seen people in their 20s and 30s, even though it's rare to see them, we'll treat them, and they seem to do very well long term. We think that we may have corrected something that they were born with or they developed perhaps as a child. I think the thought about whether we cure this problem in the long term for middle-aged or older people, it's not quite clear. And where some of us are reluctant to use the word cure for that, and why is that? Well, because there's certain things that make AFib happen, and the procedures that we do, they're designed to eliminate the triggers and circuits that you have today. Okay, so for example, in 2018. But we don't cure hypertension, diabetes, heart disease. We treat it, we manage it. But we can't cure those things, and we can't stop you from getting older, whether you call that a disease or not. One consolation, we're all getting older at the same rate, but the older you get, your atrium continues to change. And so what you might see is people, far out from ablation, 5, 10, 15 years, actually develop another abnormal heart rhythm. And so it's more just a progression of the diseases and the process that makes you develop abnormal circuits to begin with. So it's one of the reasons why with blood thinners we're very reluctant to stop them, even if we think that things are going well from a rhythm standpoint, because of the concern that that might happen in the future. But the last thing I would say is a lot of us are using sort of almost like an oncology or cancer analogy for atrial fibrillation now. So you have atrial fibrillation, it can progress over time. We're going to manage it, whether you just choose to use medicines like chemotherapy, or you choose to have procedures like catheter ablation. Our goal is to get rid of the AFib today, put it in remission, for example,
Right.
and monitor you over many, many years to see, because for some people they will be cured, and for some others they may have a recurrence down the road, and then we revisit the options that are available at that time. But I think in terms of a lifelong disease, I think what you really need to have is a lifelong relationship with someone who can manage this for you, whether that's your primary care doctor, your general cardiologist. We as electrophysiologists most often get involved when we're looking for either invasive treatments or it's a little bit unusual. But it's certainly having a lifelong relationship with someone, even if you're feeling well and you think you're doing well, that you keep in contact with them.
Right, right. And this kind of goes along with this next question. I think I might know how you're going to answer it. But Gary asks, why do I have AFib?
Gary, why do you have AFib? I'm not sure. There's a lot of reasons why people develop AFib, and we mentioned a variety of them in terms of risk factors. And for most people, I would say, Gary, it's not one particular thing. There's a certain, percentage of chance. We talked about genetics, people developing other risk factors, diabetes, hypertension, heart disease. And those are things sometimes that we can't control at all. So that's beyond our control. And so it's not to say that you're responsible for developing atrial fibrillation, it's that atrial fibrillation happened to you. I think on the flip side, though, there are things that we can control that make us have AFib that we do have control over or can get better control over. And those are things like being more active and exercising, diet, weight, seeing your doctors regularly, making sure you take your medicines, making sure your blood pressure is controlled, making sure that if you have other disorders like sleep problems, you see a sleep doctor, reducing alcohol, stop smoking. These are things that hard to control, no doubt, but certainly can be controlled, if motivated and you have the support system and desire to do it. So that's sort of the way you look at it, because there's some things we can't control as why you get fibrillation, but there's certain things that we can control. And we try not to beat ourselves too much about the things we can't control, so don't want to blame your parents or anything. It's just this is the way it is. But certainly really focus and be energetic about the things we can control, working together on trying to deal with those.
I like that philosophy.
But I'm sorry you have AFib, but you're not alone. You're definitely not alone, Gary. So
definitely. So Joanna asks, when should a patient see a cardiac electrophysiologist?
Yeah, I think, well, the global answer would be you can see an electrophysiologist anytime, okay, if you can get an appointment. So, because electrophysiologists, we deal with AFib in many different ways. Do all AFib patients need to see an electrophysiologist? And my answer would be not necessarily. There are many qualified physicians, primary care or cardiologists that can manage atrial fibrillation well, because this is such a prevalent disease. So I think managing blood thinners or stroke protection can be done. You don't need to be an electrophysiologist for that rate control. I think people who are now leaning towards more of a rhythm control strategy and using the medicines that are heart rhythm stabilizers, these antiarrhythmics, I think those people should come and see an electrophysiologist. I think because, number one, you want to make sure that the medicines you're using are going to be safe and appropriate. And we have a lot more experience with them because we write them routinely. But also because we want to talk to you about other options that may be available to you as opposed to medications. So either catheter ablation, or we have familiarity with surgical procedures for atrial fibrillation, even though we may not personally perform them, or sometimes we do them together with the heart surgeon. So I think people who are doing well in atrial fibrillation, who heart rate's controlled, protected from stroke on blood thinners, and are stable, don't necessarily need to have an electrophysiologist on their team. I think people who are having problems with that, for example, or who are looking to explore other options, and especially using heart rhythm drugs, I would encourage you to seek out an electrophysiologist to get an opinion and learn more about options, about what may be available.
Great, good advice. So this one is from Anonymous. How does fainting or a lightheaded experience relate to AFib?
Yeah, so Anonymous, I think, those symptoms of lightheadedness and dizziness and fainting definitely can be related and be caused by atrial fibrillation. So, and remember, we lose consciousness or faint because we don't get enough blood flow to our brain. And so for certain people in atrial fibrillation, if the heart rate is really fast, and that bottom pumping chamber can't fill with blood, and the blood that it squeezes out is pretty low. People can pass out from that, but it's unusual. I think fainting from atrial fibrillation and rapid heart rate is an unusual symptom. What we probably see a little bit more so is when people transition from atrial fibrillation and then they come back to normal rhythm. People can faint from that as well. So what's going on there is you're in atrial fibrillation, you might be really fast, and let's say you're on medicines to slow down the heart rate, or that as you convert from atrial fibrillation to normal rhythm, something's got to give you heartbeats after you convert. And that thing's usually your sinus node, your natural heart timer. Sometimes the sinus node that lives in the same electric grid as the atrial fibrillation does can get beaten up and diseased over time, and it doesn't work well. And people can develop slow heart rates from that. And sometimes we see as people transition from rapid electricity to normal, you get a long pause and that sinus node is stunned, it's weakened, and it can't keep your heartbeat in time. People pass out. And sometimes the medicines we use to slow down heart rate and control rhythm actually can make that worse, ironically. So I think anybody who has atrial fibrillation, who has fainting or near fainting, those are red flag symptoms for me, and they really need to be aggressively evaluated, both for safety and to see what else that we can do, because that may be a situation where if the heart rate's slow, we use devices like pacemakers to help people.
So potentially something else going on, so best to seek consultation. So next question is from Ida. Ida is 80 years old. She's hanging out on Facebook today. And what she's wondering is, she heard you say that age is a factor, considering atrial fibrillation. But what she wants to know is, will an ablation be done at 80 years old?
That's a good question. So Ida's 80, and would an ablation be an option for you to manage your atrial fibrillation? And I think the answer is, at least in my practice, but it depends on which centers and which physicians that you see. We don't discriminate based on age alone for this problem. So we offer the same therapies for whether people are younger. I think most people we do perform atrial fibrillation ablation procedures on, they're probably in their mid-60s or 70s, because that's where we see a lot of the percentage of people with atrial fibrillation. But as I mentioned, the older you are, the more likely you develop AFib. We don't have an absolute age cutoff in terms of who to say is not a candidate for ablation, just based on your date of birth. It really is considering everything in total about other diseases you have, how bad your quality of life is, what you've responded to in the past, how willing you are to have an invasive procedure, even though it's non-surgical. There's still that risk. And what your goal is. Is your goal looking for longevity? Is it quality of life only? Is it to get off medicine? And so we take all of that into account. I think what we've seen in the past is a bias to only offering the procedure to younger people because we knew that they may have a better outcome. And I think that's true. The older you are, the success rate may be affected because there's a lot of other illnesses that may happen, or your atrium is not as young as someone who's younger. Just like skin ages over time, the same thing happens to the atrium. So, but at least in our practice, the oldest person that I've done an ablation on is 82 years old, and the youngest is 19. And we look at those people individually. We don't just have an absolute age cutoff where we say we're not going to offer that. And there has been some publications about doing ablation in octogenarians, showing good outcomes and safe procedure rates to do it. So at least for me, and I can't speak for all centers and operators, we are less focusing on that alone and looking at the person in total to make that decision, if it's something that they want to do.
That's great news for Ida. Okay, we have another Marianne, and she asks, would you treat AFib that occurs a couple of times a year?
So atrial fibrillation that happens a couple times a year, so pretty rare. Maybe it's not affecting quality of life, certainly not on a daily basis. So we see what we treated, I think, take a little bit of a step back, and when we talk about treatment, we're talking about treatment of all the four pathways, right? So even if you have atrial fibrillation once per year, but we feel that you're high risk for stroke, whether you have 1 episode a year, 2 episodes, or you have 100 episodes a year, we're going to recommend that you get stroke protection. And for most high-risk patients, that's going to be at least trying a blood thinner of some kind. So that's how we would manage that portion. I think for very sporadic AFib, we still focus on risk factors. to try to get that 2 per year to 0 per year, maybe 1 episode in 2 years. And so looking at all the other diseases and looking at your lifestyle to really try to manage that. With regards to, medicines for rate control, rhythm control, catheter ablation, for example, 2 out of the year, depending on how bad they are, it depends. I think for most people, if they're very rare and they don't really affect them that much, going all the way down an invasive procedure may be aggressive. I can tell you that, in my experience, most people who have that burden are probably not going to choose to do something like that. May want to do medicine as needed. So we do a therapy called pill in the pocket. I had an episode, maybe this was 6 months ago, I had another one. I don't want to take medicine every day just to prevent 2 episodes in 12 months, but let me take some medicine now to slow down my heart rate, maybe medicine to bring me back to normal. And then once I'm back to normal, maybe cover myself for another day and then stop it. Right? So as needed therapy, pill in the pocket we call it. That would be reasonable for that.
Treat on the spot, okay.
But I can tell you there's some people that AFib not only just causes physical symptoms. I have several patients who it really causes them other quality of life problems because it's more of a mental thing. These are people that maybe have very rare AFib, but the symptoms in the episodes are so disruptive and affect them so negatively that actually they live a little bit in fear of having an AFib episode. These are people who are reluctant to travel to a remote place. They're worried that maybe I'm out somewhere in the mountains and there's no emergency room. Right. And I'm an AFib and maybe I'm by myself. So I think those sort of mental symptoms of having a recurrent, progressive, and often lifelong illness, we don't want to ignore those. And I think that's reasonable to consider into the mix of how aggressive you want to treat your AFib.
Right. I think that's so great that you can consider that aspect of things as well.
You want to live well. So
absolutely. So last question from our audience. Kai asks, I had a stroke from AFib in January. I'm on a beta blocker and an anticoagulant. I've been getting palpitations. What can I do to stop them?
Yeah, so Kai, I'm sorry that happened to you. I hope you're doing well after that. Mentioning being on the blood thinner, the anticoagulant, that's really important because obviously you've declared yourself to be high risk with this atrial fibrillation. So that's going to be a long-term preventative treatment for you. In terms of the palpitations, it sounds like you're still having symptoms of atrial fibrillation. So remember, the blood thinner is only to protect you from stroke, so it's not designed to make you feel better in terms of the physical part of AFib. Beta blocker is a medicine that slows down the wires of the heart, top to bottom, so that can help control the pulse when you're in atrial fibrillation. It may have a very small effect in preventing atrial fibrillation to begin with for some people, if they're adrenaline sensitive AFib. But beta blockers in general are not very good rhythm stabilizer agents. So you could be experiencing palpitations for a couple of reasons. One is that you're having atrial fibrillation and your heart rate's still too fast. So maybe you need more medicine or additional medicine to control that down. And the only way to do that is to either document it on a heart rhythm or listen to your heart rate to get a good objective. Taking your pulse in AFib is sometimes a little bit tricky because some pulses are strong, some pulses are weak, and sometimes we can underestimate how fast you are. But it also could be that your heart rate is fine in AFib, but it's the rhythm itself and the irregularity of the pulse that you don't like, giving you these palpitation symptoms. And that's where a strategy of rhythm control, using either medicines or procedures to prevent AFib from happening, can help you. And that might be something that you want to talk to your doctor about. Which is it that I'm having? What can I do to adjust what I'm having now? Maybe do I need more medicine or different medicine? Do I need to explore a rhythm control option? Right. Because based on the medicines that you're telling us right now, you don't really have a primary rhythm control medicine on board, at least for now.
Good. Thank you.
Yep.
And I know, I feel so much better about the procedure, what to expect. You took us through so much in an in-depth way, so thank you.
Yeah, my pleasure.
If there's any last things that you want to leave with our patients about AFib, any big take-home messages?
Well, I think for people who are watching, I would just congratulate you on having the desire and the motivation to learn more about this, whether it's for you, whether it's for a loved one or someone, or just for your own education. I think there's a reason why the September is AFib Awareness Month. Is because the awareness of AFib is not that great. And it should be, because this is a disease that really affects millions of people. I bet you most people know someone or have some relation to someone who has atrial fibrillation. And I think what's going to happen is we're just going to see more of it in the future as our population continues to age and the risk factors that we have. So I would encourage people to really just learn more about it, even if it's something simple, like a post that says, do I have AFib? But certainly sitting on a webcast for 60 minutes listening to me and you, I really commend that. And to be proactive about it. I mean, if you have atrial fibrillation, there are a lot of resources available out there, not just in-person communities and support groups, but online and virtual, obviously Facebook being an example of that. And learning from other people's experiences of what worked for them, what didn't. Because this whole age where information is so available and information comes out so quickly, both from patient experiences, but our side of how we can treat and manage and deal with this problem, to keep pace with that really takes some regularity. And so I would encourage you that you continue to every once in a while update yourself, like I do, my colleagues do. What's new with AFib? How are the treatments doing? What am I worried about this time? What are we learning about the disease? Because we're really focusing on this problem big time. Big time now. There's a lot of resources, a lot of time, a lot of smart people trying to figure out things about it, what causes it, how we best can manage it. And that means all this information is coming out, and we need to absorb that in a good way. So I would just keep doing what you're doing. If there's any one thing that you can do, is just keep learning.
Great. Well, thank you again, Dr. Kang. Your patients are very lucky to have you. It seems like you have very trusting relationships. I love the way that you set it up with your patients. Listen, it's a lifelong journey with them, so that's fantastic for everyone here in Oakland. Don't forget that next Monday we have our last episode of the Facebook Live series for AFib Awareness Month. We're going to be coming to you live on the 24th of September at 3 p.m. with Dr. Brett Gidney in Santa Barbara. And you won't want to miss it. We're going to be touring a AFib cardiac cath lab where the procedure takes place. So we're going to be going one step further than we did here with Dr. Kang today. You'll get to see some mapping images where you would receive the ablation, so you don't want to miss that episode. Thank you so much for joining us today, and I hope everybody has a good rest of the week, and we'll see you next Monday.
Thank you.
Thank you.